and sterilise, getting out of the car to save time, and then the facilitator will help them prepare the groin area for cannulation. And you may say, well, hang on, we're only 5 minutes into cardiac arrest. I don't want to go onto ECMO at 5 minutes, so I'd like to try and get a ROSC, please. And you'd be quite right. But all we're doing at the stage is putting wires into the femoral vein and the femoral artery. And we're doing it percutaneously, just like we would a central line and an arterial line. And to be honest, if you've had a cardiac arrest, even if you ROSC, you're going to get an arterial line.
Okay, through the cord.
Okay? And if you get a good ROSC and the patient sits up and goes, what's going on? We just pull the wires out. Wires are very low morbidity in femoral vessels. Okay. They're not no morbidity, but if you've had a cardiac arrest, it's not going to be the biggest thing. That's a problem with that day. Okay, so we're going to go straight to wires. It doesn't commit us to ECMO. And you may see, if this happens, wires going in, it doesn't mean the patient's going on to ECMO, and that's a really important point. But it's a crucial saving time step for us. So we've got funky portable ultrasound, which I don't know if they can see on the screen, but it's all these kind of things that help save a little bit of time.
2 minutes. When you're a rhythm check.
Mammoon is basically going to use our ultrasound to identify femoral vein, femoral artery. It's going to be on the same side in this manner because fidelity is a little bit low just because you want to hit the screen down. During this time, he's completely focused, a task focus on the wires. He won't even know how old this patient is. He's not even starting to think about inclusion criteria. He's focused entirely on getting wires into vessels. And the Rob, who's a facilitator, is his bandwidth. So he's the go-between between the advanced team and the exit team. So in this simulation, this patient's in VF, okay, and it's refractory VF about 5 minutes in. So all this time, ECMO below the waist, everything above the waist is just as you would do with ECMO 1 and 2. It's exactly the same algorithms, it's exactly the same drugs. In terms of airway, well, it looks like they've secured a definitive airway. To be honest, it doesn't matter whether it's a tube or an iGel or a sort of LMA. All that matters is the ventilation, oxygenation. The ET tube, if required, if a benefit, great. Perfusion is setting up the kind of the Apple map of the ECMO world, the cardiac health. So they've got a circuit that they're priming and getting ready, which is going to be the circulation of this patient if indeed they do hit criteria. So Simon, who's leading the cardiac arrest, will also be starting to think about some of the inclusion criteria. He'll start to think about whether they hit the age. He'll be really interested in the end-tidal CO2. So end-tidal CO2 is 1.5 kilopascals. If you have that, or less, 20 minutes of CPR, you might as well stop. There's very strong evidence that end-tidal CO2 doesn't predict success, but it does predict failure. If the end-tidal CO2 is low, 20 minutes, universally the outcome is poor. So our inclusion criteria is 1.3 to 1.5. If at the 20-minute time out, the end-tidal CO2 is that low, then they will fall out of our inclusion criteria. The other thing that's awful prognostically is asystole. Okay, if they have asystole, then we won't be putting them on ECMO because you have to think of what asystole is in terms of a rhythm. It means that all the pathways have been exhausted. They've gone through this kind of metabolic slide to the point where they can't even generate a flicker of electrical activity in their cardiac system. And the thing that's important about that is by the time the heart runs out of reserves to even create an electrical pathway, the brain will be absolutely wildfire hypoxia. So it's more, it doesn't mean that you can't possibly get a ROSC with asystole, it just means that you will be incredibly unlikely to get a ROSC with an intact brain. So you can see that there's challenges with compressions by trying to thread little wires. You've seen the charts that show that CPI generates pressure, and then when you stop compressions, it falls back down, and it takes time to build up. So in a normal resuscitation, you're at pains to avoid interruptions in compression. However, for someone that's going to hit criteria or is looking like they might hit criteria, actually ECMO is going to be the thing that's most likely to be of benefit as they enter the refractory stage. So we will you may see us pause just to pass a wire at that stage. And we may say to delay shock for a second to have hands off wires. Like normally, I know we're moving to a kind of, we've lost all the metal things that can arc and give you electric shocks. And most of the time you can hold a patient while they're shocked to be absolutely fine. But we've got wires in their heart, so that's the one time we might get a little bit of warmth with the shock and we're holding one of those wires.
Okay, Simon, we have control of both vessels.
So, what stage do you have them in?
Control of both vessels.
So once they've got control of both vessels, they're going to put long wires in, okay? So they've got one thing in the femoral vein, one thing in the femoral artery. So we need to know where they are. So we do a kind of process of elimination. It's very hard with ultrasound to see how good aortic reads. So for the vein, they'll put the wire in, and then Rob will hold the ultrasound and will show the wire coming up the eye. You see the inferior vena cava up to the right atrium, and we'll know, therefore, it is in the femoral vein. And then when we put the wire in the femoral artery, we'll have the same view, but we won't see the wire. And if it feeds nicely, and we don't see the wire in the vein, we will assume that it's in the artery. We'll accept a 5 to 10% fail rate at percutaneous access to the vessels. In our experience in ECPR, if we can't get wires into veins, because in arteries, most of the artery, because they're so small, universally the patient dies. And it's because the vessels are a reflection of the state of the patient. They've either gone through their catecholamine curve and they're so constricted, or they've got such bad vasculature. Every time we've done a cut down in these patients, they haven't survived. So rather than do cut downs in patients that we think are going to die, we will accept 5 to 10% fail rate, knowing that the ones that we do get in are much more likely to survive. So, have you got both wires in? So at this point, the ECMO team are not committed to ECMO. They can just take that out. But the next stage, big dilators, is a commitment. Okay? Now, if they've done this before 20 minutes of collapse, then they'll just wait. Because we're not going to go on before 20 minutes, because ethically we want to give them gold standard treatment, which is 20 minutes of resuscitation. Okay, and it doesn't take us long to go on from this stage. And certainly for our sub-30 that's got ethics approval, it's half the reason is that we were not taking away from what they would get if we weren't there. Okay? So 20 minutes, which conveniently is coming up right now, the team will go through a checklist. So you have 20 minutes, guys.
Okay. Simon, could I have the choice that we do the checklist now? Sure. To you, Rob. Thank you. Perfect. We're going to run through the ECPR eligibility criteria. 18 to 65 years old.
Check.
Witness collapse.
Check.
Presumed cardiac etiology.
Check.
Less than 2 to 3 minutes until chest compression started.
Check.
Electrical activity on ECG.
Check. Clear.
End tidal.
It's currently 6.
Perfect. No severe comorbidities that we're aware of.
Check.
Not pregnant.
Check.
And not wearing any study braces. Perfect.
Check.
Okay, so you hit all our criteria, at which point carry on CPR, but we're now course committed to ECMO. The patient's now going into ECMO. Okay? So effectively, what we're going to do is dilate those wires and put in some big tubes. That's effectively it. We'll give a bit of heparin, so you might hear us ask for a bit of heparin. The reason being that what we don't want is clot to form around the aortic valve and in the root, and then prolonged CPR and low flow patients. That can happen quite quickly. And we don't want our circuit to clot, because that wouldn't be good for anyone involved. So you'll get a little bit of heparin at this point. Also, we'll probably put out a pre-alert to Brighton, because even though if they get onto ECMO, they're going to be stable. We don't need to rush at a crazy pace. They still need the cause of their cardiac arrest sorted. The vast majority of people who have cardiac arrest have coronary artery disease. So as a routine, these patients will go to Brighton Heart Attack Centre. If they're in London, they'll go to Barts Heart Attack Centre. And they'll have an angio whether or not there's any ST changes or risk factors. Because it's an important negative if the coronary arteries are all flipped. They also get CT heads, CTPAs, look for other reversible causes. Because, as I said, if we can't reverse the cause of the arrest, ECMO is just buying time into a complication. So that heart needs to recover somehow. So we need to come up with a reversible cause. Most of the young people that arrest will be cardiomyopathies or channelopathies. And actually, you'll get a lot of stunning from the heart after their cardiac arrest. But if they're young and they've had good CPR, it tends to be more stunning than infarction. The hearts do tend to recover, normally on a 3 to 5 day kind of time frame on ECMO. So at this stage, mammalian is effectively serially going up on giant plastic things that make big holes. So this is where we can cause a little bit of damage if the wires aren't in the right place, but happily it doesn't happen very often. So it's not a no-risk procedure going into ECMO. It does carry with it some risk of problems. However, if you're at 20 minutes, which this patient is a cardiac arrest, then anything pretty much is a best interests intervention, because without it, your chance of survival, as we'll see, is 0.0 something with a normal brain, returning to a normal quality of life. So the sterility is something that people often ask about in pre-hospital ECMO, compared to nice conditions of a theatre or a heart attack centre. We do what we can, so we use chloroprep. Everyone is as sterile as they can be. We have sterile drapes. Interestingly, the only complication in the 150 patients that the French have done that they've reported is a cannula dislodgement, no added infection. And really interestingly, if you're interested in infection control, which I'm not, but if you are, we have patients that have big pipes put in very quickly in not ideal situations, who have those big pipes for months. We have hardly ever got an infection from an ECMO cannula. Now that may be because the flows of the blood's quite fast, but there's still venous cannulas sitting in groins and necks, sometimes for months. It's just quite interesting when we see peripheral cannulas getting infected in 3 days, and then we've got these giant things but in less than sterile conditions that don't seem to get infection. If I was interested in infection control, I'd be interested. So another question we get is, now we've course committed to ECMO, what would happen if you suddenly got a ROSC at this late stage? And the answer is almost certainly we would go on to ECMO anyway. Okay? The vast majority of people that we put on ECMO aren't in cardiac arrest. They just have heart failure, they're in cardiogenic shock. And this amount of CPR, this patient is going to have a degree of cardiogenic shock. And actually, we talk about ROSC and getting the heart restarted. We see a lot of arrests come into a heart attack centre, and the heart's restarted and everyone's high-fiving, but they've got a systolic of 70 and they're on huge amounts of adrenaline and noradrenaline. And these support drugs are flogging the heart, they're asking a hurting heart to work even harder. And actually, ECMO prevents you having to use those inotropes and pressors. So there's a lot of interest in putting patients very early now onto ECMO, cardiogenic shock, to avoid using inotropes and pressors. So in a best evidence situation, I think we would still say we're pretty justified going on to ECMO, even if we get ROSC at this stage. So when Mamin's got their big pipes in, he's going to take the circuit from the perfusers, which is a sterile circuit again. So when he connects up, within a minute there'll be what's called full flow. And at that point, the rest of the team can kind of breathe a sigh of relief. We still ventilate patients, which is something else that people ask, but you don't need to ventilate very hard. You can lung protect on a slow respiratory rate and bring the FiO2 right down, because the ECMO is doing the job of the lungs. In terms of compressions, sometimes some people advocate continuing compressions even on ECMO for a bit, just to prevent any clot forming around the aorta and the aortic arch. I think we kind of judge it per case as to how long the CPR has gone on, how worried we are about the clot. We probably use echo to have a look and see whether the aortic valve opens. Now, once they go onto ECMO, they're not going to get any more shocks, even if they stay in VF. And the reason for that is that we know that all their organs are perfused, and actually, the vast majority of patients in VF that go into ECMO, the ECMO provides really good coronary perfusion, and they go into a perfusing rhythm spontaneously without electricity. You just see the VF suddenly going into a perfusing thing, because you've suddenly given those coronaries the perfusion pressure they've been missing. So there's no point in shocking. You've got to think what you're trying to achieve. By 20 minutes of a refractory, electricity is not going to make any difference. Coronary perfusion pressure will. And we're not going to give any more adrenaline. We don't like adrenaline. We only give it because it's part of the ALS algorithm. But as per paramedic 2, if we didn't have to give it, we wouldn't. Okay. Yeah, so tomorrow we'll be using a Lucas. Again, there's no evidence for mechanical CPR in terms of big studies. There's a million reasons why you might not see that advantage. Actually, anecdotally, it's right by the flow, and we would use mechanical CPR. Okay, so my minister is clamps up, so it's going on. We realised that we had just saline that didn't look like blood, so in the last minute you may have seen Mamoon sneak on and inject red wine into the circuit. There's 2 glasses of red wine to try and give it a red tint. Okay, so they're at full flow. Okay, so at this point we may probably stop compressions. But at this point, this circuit is draining 4 or 5 litres a minute. Okay, going through the circuit, 4 or 5 litres a minute, going back into pressurised into the artery, up the wrong way up the aorta, which may sound a bit weird, but it doesn't really matter, at least initially. And so this patient at this stage is getting full perfusion of brain, heart, most importantly, and then lung, kidney, and everything else. So at this point we have a more relaxed, still urgency, but no haste, a nice relaxing packaging. Someone will always stay on the pipes, will secure them, sutures, stick them all down, make sure that we're happy with the battery, make sure we've got oxygen, we've got post-ECMO checks to go through to make sure everything's happy. But then we would be getting onto the ambulance and heading to Brighton, where we would have a look at the coronaries, make sure the leg's okay. And then we would take the patient back to Barts onto our ECMO unit. So we should probably give a hand to the guys. That was a phenomenal effort. So from the time that the ECMO guys were there, so to go onto full flow was 15 minutes. So of course it's not a real person, of course there are things that slow you down in real life, but we do ECPR and it's not that much longer. So we think we wouldn't do it if we thought we were going to take 60 minutes. Then we would wait at the hospital. But we think that we can achieve it much quicker, and we think that that might give us a chance of improving survival. By no means guaranteed.